presentation. CIPKON. So I would like to have everyone's attention, active involvement, any issues, questions, clarifications, because same will be presented there. Any faults, any shortcomings, we can point out so that can be corrected.
So for the paper presentation, we have been allotted a time of 5 minutes for the presentation and 1 to 2 minutes for the question and answer round. And the total number of slides, including the title slide in my presentation, should be 8. And each presentation should have not more than 8 lines. So should I begin?
So
Good morning, everyone. My paper presentation is a case series on anxiety and mood symptoms after single cannabis use. Now, cannabis is the most frequently used illicit psychoactive substance worldwide. In 2012, it was estimated that 125 to 227 million people used cannabis. The National Survey on Extent, Pattern and Trends of Drug Use in India also found it to be the most common illicit substance used in the country. Now, cannabis also has widespread recreational use worldwide. The recreational use is commonly associated with leading to a feeling of euphoria with decrease in anxiety and increase in sociability. However, cannabis use has been associated with a high incidence of psychiatric disorder. Now, here we report 3 cases of patients who developed anxiety and mood symptoms after their maiden use of cannabis. The patients were admitted in the inpatient department of a tertiary care hospital. Their baseline investigation sent, and they were managed symptomatically. In the first case, we had a 31-year-old female who presented with complaints of low mood, forgetfulness, headache, sleep disturbances since 3 years after having consumed bhang. Now, she further reported a lack of interest in her day-to-day activities, pessimistic views towards life, ideas of helplessness, along with forgetfulness, a lack of focus, complaints of derealization, and frequent awakenings in the night. Her HAM-D score came out to be 20. In the second case, we had another female patient with an almost identical profile who presented with complaints of ghabrahat, restlessness, pain in the lower back, and sleep disturbances since having consumed cannabis in the form of bhang 2 years back. She reported of heaviness in chest, palpitations, restlessness, and feeling on edge all day, along with a sharp and radiating pain in the lower back. The sleep disturbances she reported of was having difficulty in onset of sleep and frequent awakenings in the night. In the third case, now we had a 21-year-old male who presented in an agitated state with complaints of bhang intake 8 days prior to his visit to the outpatient department, with also reporting of complaints of over-talkativeness, increased appetite, hearing music not heard by others, irritability, anger outbursts, restlessness, and decreased sleep since 7 days. His YMRS score came out to be 36. Now, during intoxication, marijuana can interfere with cognitive functioning and motor functioning. Cognitive functioning being memory and perception of time, and motor functioning being coordination. And marijuana, like other drugs, can result in addiction. Evidence suggests that cessation of heavy or prolonged cannabis use precipitates withdrawal symptoms, mainly mood and behavioral symptoms, and there's an up to 6 times greater risk of developing schizophrenia in frequent cannabis users. Frequent being those who have used cannabis more than 50 times in their lifetime, as compared to those who have never used it. Now, this risk being higher if cannabis is used before the age of 15. The symptoms of all of the 3 cases we reported arose after a single episode of consumption of cannabis. So it is probable that even a single instance of consuming of cannabis for the first time can lead to long-term psychiatric manifestation. As policy shifts towards legalization of marijuana, it is reasonable and probably prudent to hypothesize that its use will increase, and that by extension, so will the number of persons for whom there will be negative health consequences. Now, the research regarding single cannabis use and its aftermath is scarce, so further human studies are required to establish consistency in our results. These are my references. Thank you.
Any questions, comments? Single intake of cannabis leading to psychiatric.
Yes, sir. I wanted to ask this only, sir. Development लिख सकते हैं इसमें? Developing mood and
I think
something.
why you saying single? Is it the first?
First, maiden use.
Then anxiety आप बोले, mood बोले, बहुत जगह I think somatic symptoms भी हैं.
Yes.
So I think first instance of cannabis, the first cannabis use and its short-term psychiatric sequelae or cases. I think this becomes more because there are varied presentations. ठीक है, कहीं आपका वायरस का स्कोप बढ़ा हुआ है, कहीं आपका एमडी का स्कोप बढ़ा हुआ है. I think that will be its sequelae. So discussion में long term नहीं आएगा because I think hardly a week till तक हमने follow किया.
So when they in the hospitals, sir, in the female patients, उनके तो symptoms they have prolonged. They have.
यहाँ पर हमने कितनी duration पे report किया हुआ है?
Sir, ये जो हमारे सर 2 years 3 years तक आए हैं सर, जो first 2 patients हैं उनके symptoms.
जब
After consuming cannabis,
single
the next
instance.
day only, single instance, since the next day only, the females they reported of low mood.
We saw them. That was after second or third year of them.
Then we saw them that was after 3 years and 2 years respectively.
I think the short term hata psychiatric sequelae. ये हमने इंजेक्शन किया जैसे कि अच्छा केस डिस्कशंस हैं, केस हिस्ट्रीज हैं, वहाँ पे क्लियरली दिस वाज द फर्स्ट एंड ओनली यूज सो दैट इट बिकम्स मोर क्लियर कि बाद में नहीं किया. सो द हाईलाइट ऑफ द प्रेजेंटेशन इज फर्स्ट एंड ओनली यूज लीडिंग टू सिंगल कंजम्पशन लीडिंग टू psychiatric sequelae, and that was varied in presentation and varied in duration. अच्छा, आपके इंट्रोडक्शन में have you set the tone adequately? You just mentioned the epidemiology. Go to the introduction. And then you're saying that there is a different presentations and high incidence of psychiatric disorder. But whether high incidence of psychiatric disorder has been established with first and single use, वो आपको एक लाइन डालना पड़ेगा. फर्स्ट एंड सिंगल यूज के साथ ये एस्टैब्लिश नहीं, ठीक है, बट यू नीड टू सी द लिटरेचर. बेसिकली कैनबिस तो एक सिंगल यूज ही हुआ एंड दैट हैज ट्रिगर्ड ऑल दिस. ये बताना चाह रहा हूँ इंडिपेंडेंट यूज हो सकती है.
You found that there is a relationship with use and then subsequently.
एक इसमें जो हिल्स क्राइटेरिया है वो आप लगा लो. हिल्स क्राइटेरिया ऑफ कॉजेलिटी होता है, ठीक है, उसको आप आप डिस्कशन में एक लाइन बोल सकते हैं. एज पर द हिल्स क्राइटेरिया ऑफ कॉजेलिटी हमारे 3 केस सीरीज कहाँ पे आए. इनटेक लिया, इनटेक के बाद प्रेजेंटेशन आई एंड देन देयर गिवन दिस टेम्पोरलिटी, देन वेदर इट इज नोन टू, तो उसके हिसाब से कहाँ फिटिंग कर रहा है टेबल में आप उसको डिस्प्ले कर सकते हैं. So that will give you more leeway for discussion. Then you can publish this also subsequently. Referencing pattern उन्होंने कहीं बताया है.
I wanted to ask sir, जैसे इसमें कहते हैं introduction, can I also say that the cannabis is mostly used as an anxiolytic, removing anxiety and
if these patients has this intention to use it for
no recreation, only recreation.
Because it is not a known anxiolytic. So तो any dysphoria कम करने के लिए कुछ पेशेंट देखते हैं वो are डिपेंडेंस पैटर्न पे दिक्कत आ जाएगा. एज कितना था तीनों पेशेंट्स का?
30, 31 and 21.
21. Basically young and middle age. बट उसमें पैटर्न एक पैटर्न ऑफ इंटेक होगा ना, यहाँ तो पैटर्न ऑफ इंटेक ही नहीं है। अगर मैं एक बार लिया उसके बाद अच्छा, ये जो सिंगल इंटेक था ये क्या था? एक दिन चला, 2 दिन चला, 3 दिन चला? Just once. Yeah, I happened to see one patient who took cannabis 4 years back, still having auditory deafness, refractory. मतलब भांग एक नीले में खाई थी। There is an article. So discussion on vulnerability. All they were vulnerable. Cannabis TSCS property. एक article है 20 years में behavioral sequel of cannabis with healthy. They all were healthy, and then they took cannabis and then subsequently had second. तो यहाँ से आप एक डिस्कशन में डालो। So if we find these 3 cases in the published, ठीक है, इसको हेल्थ स्टाइल में लगाते ही राइट इट अप। वो जर्नल में करेंगे संडे।
Morning. I have been given 10 minutes to present this paper. Good morning. The title of my paper is Efficacy of Adjunctive Theta Burst Transcranial Magnetic Stimulation Acute Phase Mania, a randomized sham-controlled pilot trial. The lifetime prevalence of bipolar disorder is between 0.1 and 4.4%. Bipolar disorder accounts for 9.9 million dailies in 2013. Acute mania is one of the most catastrophic phases. Pharmacological interventions including mood stabilizer and atypical antipsychotics, which have frequent side effects, which result in approximately 50% of non-adherence. Hence, novel and effective treatment strategies are needed. RTMS is a promising therapeutic tool for refractory neuropsychiatric disease on the basis of neural network modulation and is a non-invasive analog to electric stimulation. A control study by Grisaru and colleagues clearly showed that right DLPFC is a better target than left DLPFC when using fast RTMS. Based on neuroimaging studies which found decreased cortical activities of the right prefrontal cortex in mania by Al-Masawi and Rubinstein, Capstan and colleague, however, failed to find a difference between active and STAM stimulation of RTMS over the right DLPFC. Therefore, we went for a bilateral sequential DLPFC stimulation, activating the right side and inhibiting the left side. Citing the breadth of the studies, we decided to study a more better version, that is theta burst stimulation of RTMS with a better study design, stimulating both the right and the left DLPFC. The aim of the study was to study the efficacy of adjunctive theta burst magnetic stimulation in acute phase mania. The objectives were assess and compare the effect of TBS on acute phase mania between active and sham. The secondary objective was to assess and compare the effect of TBS on clinical global impression in acute phase mania between active and sham. Coming towards the methodology, the site of the study was Sri Guru Ram Rai Institute of Medical and Health Sciences, Dehradun. It was approved by the ethical committee and registered as well. The sample size was calculated using G-power tool, targeting at least medium effect size of power 0.51, value of alpha error probability being 0.05, number of groups being 2, number of measurements being 3, with 25% dropout rate, with statistical test being ANOVA. Total sample size came out to be 40, 20 in each group, we conducted a pilot study with a sample size of 20 patients, 10 in each group. The inclusion criteria included patients between 18 to 59 years, right-handed patients, fulfilling the diagnosis of mania, and subjects with at least moderate to severe illness that was baseline YMLS score more than 26. The exclusion criteria is history of significant brain injury, surgery or neoplasm or malformation, neurodegenerative disorder or history of seizure, history of ECT within the past 6 months, pacemaker or any other metal parts in the body, a diagnosis of mental and behavior disorder due to use of psychoactive substance in a harmful use or dependence pattern, except nicotine and caffeine. Block randomization was done. The patient will be sequentially and randomly assigned into 2 groups using blocks of random number sequence. The number will be written in a sealed opaque envelope. For each patient, the envelope was opened immediately before the initiation of the first session by the clinical administrating the TBS. All patients were inpatients and underwent regular physical examination. Usually, the patients were admitted for a period of 2 weeks during which TBS sessions were delivered. The follow-up assessment was done post-discharge. Patients were required to continue the psychotropic medications at the same dose for the entire duration of the trial. None of the patients were provided any kind of psychotherapy. The stimulation parameters, a MAG Venture MAG Pro R30 device with theta burst boosters and V65 coil was used. For passive stimulation, the coil head was turned. Standardized international 10:20 EEG system was used for positioning the TMS coil. Active continuous TBS protocol consists of a burst of 3 pulses delivered at 50 Hz, which was repeated every 200 milliseconds for a total of 600 pulses. The CTBS will be targeted to the left side. The ITBS protocol consists of 3 pulses at 50 Hz, repeated at a rate of 5 Hz. 20 trains of 10 bursts given at 8-second interval with a total number of 600 pulses. The ITBS will be delivered over the right DLPFC. Both groups received a total of 10 TBS sessions, 2 sessions per day, 30 minutes apart, 5 days in a week, an intense protocol. 3-point rating will be done at 0, 7, and 21st day. Screening standard questionnaire for RTMS and hardness preference schedule was applied. Vitals were charted. A detailed physical examination was done. Social demographic data was collected. Tools were social demographic and clinical data sheet, hardness preference schedule, a screening standard questionnaire for RTMS, vital monitoring sheet, RTMS side effect checklist, Young's Mania rating scale, clinical global impression bipolar illness scale for rating the severity of manic episode, the degree of change from the immediate preceding phase and from the worst phase of illness. Blinding procedure. The subjects were rated on clinical measures by an independent rater who were blind to the randomization of TBS groups into active and passive. The patients were also blind to the arm of the treatment, which was determined by asking the participant to guess whether he or she was receiving an active stimulation. 55 patients were assessed for eligibility, out of which 20 were randomized, out of which 10 received active stimulation and 10 received sham stimulation. After which intention to treat analysis was done and all the 20 patients were analyzed. The statistic analysis. Categorical variables were presented in number and percentage, while continuous variables were presented in mean, plus, minus, standard deviation, and median. Repeated measure ANOVA was conducted for quantitative variables, and qualitative variables were correlated using chi-square test. The data was entered in MXL spreadsheet and analysis was done using statistical package for social sciences version. Test of normality was applied, normal probability test and Kolmogorov-Smirnov test. Number of episodes and motor threshold failed to meet normality and man-Whitney U test was applied. ITT analysis was applied, which included all participants irrespective of them completing the study. Comparison of social demographic profile and clinical variables as the ITT group was done across 2 groups between active and sham, in which age, duration of illness, motor threshold, antipsychotic dose, medical morbidities, number of episode, gender, vital status, religion, habitat, social economic status, employment, education were comparable. No major side effects were reported. 3 patients out of 2 in active, 1 in sham reported headache which responded to analgesic. None of the patients discontinued due to side effects. Results at baseline, except Weimara's, other pathological scores such as CGI, BP, S, P, and W were comparable in active and sham. We did not find a significant group time effect for all clinical variables when covariates were included in the ITT analysis in the Weimar scale and in CGI BP scale. Response rate, Weimar score reduced by more than 50% from baseline till the 21st day was considered response. In active, 80% people showed response, while in passive, 70% people showed response. There's a decrease in anterior metabolism on the right side and a relatively increase in metabolism on the left side in patients with mania, which is opposite of what is observed in depression. Our study is one of the first randomized controlled trials sequentially targeting the right and the left prefrontal cortex with intermediate TBS and continuous TBS for treating acute mania. Our study targeted correcting the altered metabolism of blood flow that is associated with mania. While feigning to conclude that adjunctive TBS is better than placebo for treating acute mania, we observed that it is safe and well tolerated. We propose the possible shortcomings of a study that might have led to these outcomes. That is, short duration of follow-up, lack of neuronavigation to target a specific cortical site biophysical models, and lack of assessment of drug compliance. Thank you.
Any questions, comments? 9 minutes. Okay. Dr. Veena, this is not for you. Any questions first? No. Sham. Passively sham.
So like I have here written active and sham. आगे हाँ sham ही करना.
प्लेसिबो भी नहीं आएगा, हर जगह शैम आएगा. सारी स्लाइड्स में आप कंट्रोल एफ करके शब्द प्लेसिबो सबको शैम पीछे जाइए, पीछे उस स्लाइड ठीक है. ठीक है, घटी ना results in non-adherence in acute phase. Non-adherence के बाद आएगा in acute phase. Bipolar acute phase. So your research is in acute phase. So hence low and effective treatment strategies are needed in acute phase. और आप जरा स्लाइड पे स्टार्ट पे जाइए. अब नेक्स्ट जाइए. ठीक है.
तो ये 0 पे ही कर रखा है, उसके बाद 1.
ठीक है. मुझे ऐड कर दीजिए.
यस.
अब ना इसमें ये सब डिस्प्ले होने से पहले आएगा current consensus. So meta analysis there. Current consensus shows discrepancy or inadequate. The efficacy of RTMs in acute phase is not established. First line.
Current studies have not been able to establish RTMS in acute phase.
This is not established. Then this study by et al. The right side is better than left side. And neuroimaging studies. This is supported by neuroimaging studies. Okay.
So I wanted to ask, this bilateral sequential DLPFC stimulation, should I add it after this?
Capstan and colleagues capsule का
Because sir, it is not supporting my study.
ठीक है, ये हटा दीजिए और you must first start with the current meta-analysis it doesn't establish efficacy of plain articles in acute phase में किया, ठीक है, and so हम लोग फिर second आएगा theta plus factor, which is
More better.
फिर ये आएगा.
Sir, should I shift this bilateral one thing, bilateral sequential DLP stimulation after this theta burst?
Because this is very important. Why you have come to this study? So first will be meta-analysis से अभी efficacy artificially established नहीं है.
Yes, sir.
ठीक है, तो we are proposing a stronger protocol, theta burst, which is a stronger protocol, जिसकी अभी studies नहीं है. ठीक है, एक चीज. दूसरा है कि why we are doing right and left, because right side stimulation है ना, ये जो DLPFC जो स्टडीज है उन्होंने DLPFC टारगेट किया, ठीक है, ये हो गया. देन कम्स टू दिस न्यूरोइमेजिंग कि हम लोग अब क्यों एक्टिव कर रहे हैं राइट साइड को और डिप्रेस कर रहे हैं लेफ्ट साइड को, उसमें न्यूरोइमेजिंग. सो दीस 4 मैसेजेस विल, नो वन विल गो इनटू दिस निटी-ग्रिटी, कोई पता नहीं, बट हाउ यू विल शेयर दिस इंफॉर्मेशन, दैट इज. एंड देन फिर आप लास्ट में अपना एम पे आ जाओ. इसको थोड़ा सा रिकरेक्ट कर लेंगे. नेक्स्ट ये रिकरेक्ट लेके नेक्स्ट. अच्छा, एक्यूट क्लिनिकल ग्लोबल इंप्रेशन, ठीक है, यहाँ पे इन है और वहाँ पे ऑन है. ऑन है यहाँ पे इन. acute phase manic symptoms या फिर on global impression in acute phase manic symptoms. दोनों में previous in acute phase और वहाँ पे भी previous over CGI in acute phase. You can take help of operation. Next. Okay. This is your ethical committee member.
Yes, sir.
अच्छा, अब यहाँ पे पूछेंगे कि why you have calculated effect size of 0.51.
I wanted
to ask you.
Sir, okay. So because we took the previous studies and saw from that, like we saw capstone and result.
तो अभी आपने इंट्रोडक्शन में बोला कि नहीं है efficacy established.
Sir, हाँ, but हम प्रोटोकॉल में ये previous studies के एग्जांपल लिखे.
कौन से एग्जांपल?
तो ये कैप्स्टन और रिसाल मेटा एनालिसिस जो आपने भेजी थी.
Basically, point is you say here that the efficacy is not established. Now, because of this, we are targeting at least medium effect size. है ना, हम लोग medium effect size anticipate करते हैं. मान लो इफेक्ट होता तो हम लोग medium की जगह और robust effect size anticipate करते हैं. अभी currently studies effect नहीं दिखा रही है. Again, so we are actually anticipating via this tool that if that जो हम लोग sample size calculate करेंगे उसमें at least medium effect size आए. तो इसीलिए alpha error of probability is 0.05, that is 95%.
Yes, sir.
ठीक है, and this and subsequently इसमें ये भी तो है power calculation. तो alpha error वो power भी तो है.
आपकी
पावर इसमें 80% करता है. पावर है ना, जो पावर कैलकुलेशन है लगता ही है. तो ये दोनों नहीं है, दोनों का प्रेजेंटेशन तो ऐसे ही है. प्रोटोकॉल प्रेजेंटेशन साथ में करना चाहिए. ये जो सैंपल फेज में करना है.
80%
And then
add कर
total sample is 40, but we are able to achieve
One-
20.
Yes, sir, I have written करने तो 5
वापस दो अब इसमें जो आपका डिस्प्ले आ रहा है रेफरेंस आपका पहले आ जाता है आप एक बार इसको किस स्लाइड पे शुरू करें
Yes, sir. अच्छा, so दो ending में
तो वो लास्ट में किस चीज का रेफरेंस है वो हैंडेडनेस का
Yes,
रेफरेंस
sir. नहीं सर, YMR score
तो उसमें जब वो थर्ड लाइन डिस्प्ले
तभी
डिस्प्ले रेफरेंसेस को भी कंट्रोल करके मिड लाइन पे रख लीजिए पेस मेकर डिस्प्ले में नहीं आ रहा तो पहले से ही डिस्प्ले हो जाता है इसलिए आपको एनिमेट करके डिस्प्ले बनाना पड़ेगा जैसे सीक्वेंस
Yes.
नेक्स्ट ठीक है नेक्स्ट
Sir, I wanted to know, do I remove this or do I let this be?
which one
Sir, all these points.
नहीं ठीक है
Sir,
ठीक है आपको बस 9 मिनट में आपने फिनिश कर लिया ना
Yes.
इससे एक्टिव एंड शैम्प
हाँ
नेक्स्ट ठीक है
So, इस पे I'm just saying the tools names.
हाँ यस यस
And I'm explaining CGI duties.
The screening standard question has been taken from our team's slot and article. ये हमने आर्टिकल मेंशन किया था वहीं से हमने लिया था subsequently many people have taken it ठीक है रिजल्ट्स पर आपको ना
तो ये सब कुछ रहने देना है कि नहीं?
ठीक है आपने नॉर्मेलिटी जो आपने बताया उसके बाद मैन विटनी यू और नंबर एपिसोड्स एंड मोड थ्रेशोल्ड डिस्प्ले सब इकट्ठे होगा तो कंफ्यूजन होगा
So, सारे इसमें एनिमेशन कर
पहले एनिमेशन नॉर्मेलिटी आएंगे फिर आएगा कि भैया ये दो टेस्ट दो जो वेरिएबल्स हैं नॉर्मल डिस्ट्रीब्यूट नहीं मिले एंड देन सब्सिक्वेंटली मैन विटनी लगा एंड देन आईडीटी
So, I will make an arrow for this as
then next इसमें एंटीसाइकोटिक करना
so, पूरा टेबल
है टेबल नहीं आपने एंटीसाइकोटिक डाला है
सर डाला है टेबल पे सर
कैसे डाला है
सर इसके बाद एक कॉलम एंटीसाइकोटिक्स का भी है, जिसमें एंटीसाइकोटिक्स का
वो
भी
टेबल का सेकंड कट करके उसको
Second में।
डाला
सर डाला नहीं, मैं डाल दूँ
ये भी एक्टिव शैप है तो
सर
इसमें whether antipsychotic dose how you calculate
सर आई हैव CPZ के साथ सर
CPZ equivalent लिया
यस सर
duration of illness full illness का
सर ड्यूरेशन ऑफ इलनेसेस
वो current episode का
यस सर करंट
नहीं, आपको clear करना पहले वाले में जाए तो पूछेंगे आपसे
सर मैंने नंबर ऑफ एपिसोड्स ही करा है
तो ड्यूरेशन ऑफ इलनेस को लिखेंगे
तो उसमें बस यही हटा दो।
नहीं जो आपने टेबल में डाला ही नहीं वो लिखेंगे कैसे तो ड्यूरेशन ऑफ इलनेस नहीं लिया आपने
नहीं
तो
सर
करंट एपिसोड का नहीं लिया
सर कंपैरेबल नहीं कर सिर्फ नंबर ऑफ एपिसोड्स
मेडिकल मॉर्बिडिटी
सर लाइक आई हैव गिवन डायबिटीज हाइपरटेंशन थायराइड एंड अदर्स
अच्छा वो आपने डाला
yes so I will add this in the table. I have just added half the table. So like इस absent के बाद
वो
मैंने
टेबल में है वही वेरिएबल्स आपको वहां पे लिखने हैं नेक्स्ट स्लाइड
ठीक है
if people will not be able to read a table, that is why you simplifying and put it in the next slide.
so the table will go in the next slide. So do I explain anything in the table
No,
or
no,
I will
just see that I'm explaining the table. Just आप table display कर दें
फिर
2
next
सेकंड
में
के लिए and then next slide. आपने explain करने के लिए लिखा हुआ है। Next. ठीक है। क्या लिखते हैं at baseline scores etc. other psychopathology scores this
वो कंपेयर
लिख देना और
नहीं सर, अब वो लिख लो।
आपने वाईएमआरएस को कोविड बनाया बेसलाइन स्कोर्स को
सर ये सर जब हमने दोबारा से कोविरेट्स करके, नहीं सर हमने एक ही टेबल कर।
ठीक है नेक्स्ट अब डिस्कशन बट नाउ इफ एस्टैब्लिश कि अगर आपने रैंडमाइजेशन किया, आपने ब्लॉक से किया और आपने सब चीजें की तो वो वाईएमआरएस आपका डिफरेंस क्यों आया?
सर वो
क्योंकि आपने ब्लॉक से नहीं किया, आपने डाला है इसलिए ब्लॉक से करना बहुत जरूरी है। यूशियन साहब देखो वो रैंडमाइजेशन में गड़बड़ आएगा, एक आपको लिमिटेशन इसमें भी डालना पड़ेगा।
सर ये वाली लिमिटेशन, so that YMRS was not comparable.
ये तो पूछा जाएगा कि क्या है लैक ऑफ असेसमेंट ऑफ ड्रग कंप्लायंस का सर?
So that we did not see that while the study was the patient taking the drugs, and मतलब we did not follow up on the drug compliance. Within after the patient was discharged, we did not know the.
बट आपके 3 हफ्ते थे उसमें पेशेंट दवाई खाया?
Yes, but sir, we did not do any type of procedure in test. That the patient was being given, but we did not see if he was the compliance was there or not. Because after that, the patient was discharged as well. Some of the patients, because I have written the rest of the analysis was done on outpatient basis. I mentioned that line as well, so sir. That is a should I do?
आपने जो एंटीसाइकोटिक डोज लिखा है वो क्या है उससे?
सर वो ये लिखा है कि patient was kept on psychotropic drugs. So
टेबल में एक्सप्लेन किया
सर वो CPZ का इक्विवेलेंट डाल रखा है सब बोला है।
तो बेसलाइन
यस सर, बेसलाइन का डाला है, सिर्फ बेसलाइन का।
बेसलाइन में आपने कैलकुलेट किया, हमें ये मिला।
ठीक है सर।
सब्सिक्वेंटली बट ड्रग कंप्लायंस अगर पेशेंट आपके पास फॉलोअप में था 3 हफ्ते बाद मैसेज किया तो आपने असेसमेंट क्यों नहीं किया ड्रग कंप्लायंस? तो आपका गलती हो जाएगा। तो अगर पेशेंट हमारे साथ फॉलोअप कर रहा है तो हमने तो करना चाहिए था। व्हाई वी डिडंट डू इट?
तो हटा
नहीं हटाना तो इसलिए पड़ेगा क्योंकि
दिस विल बी क्वेश्चनिंग अस।
आपके नॉलेज में है तो थोड़ा ही तो हम लिखेंगे कि एक इसमें आप ये डाल सकते हैं कि स्टेट बेस्ड वेरिएशंस वर नॉट considered or were not state based variations were not kept homogeneous. एक आप लिमिटेशन डाल सकते हैं। दैट मींस कि आप जो आर्टिकल्स दे रहे हैं वो कह रहे हैं कि आप इस पॉइंट पे फोकस करें, ठीक है? क्योंकि वो कह रहे हैं कि अगर आप पेशेंट पॉइंट पे फोकस नहीं कर रहा है, पेशेंट इज गोइंग हियर एंड देयर इन हिज within his realm in his mind, Artemis efficacy is being deferred. So वो state based variation आ रही है, वो एक आप डाल सकते हैं। बट फिर भी ये रैंडमाइज नहीं हुआ, ऐसा क्या करें? हम कह रहे हैं वहाँ रैंडमाइज ऐसे की करते हैं, बेसलाइन स्कोर्स मतलब जो मेन क्लिनिकल वेरिएबल उसी का नहीं है। अच्छा आपका डेटा शीट आपके पास है?
यस
एक बार लेके आना, इसको कोवेरिएंट बना के देखते हैं। अभी कर लेंगे आराम से। तो कोवेरिएंट बना के देखते हैं, हो सकता है आपको थेरेप्यूटिक एफिशिएंसी आ जाए। कि वाईएमआरएस किसका ज्यादा है? ये एक्टिव का ज्यादा है, पैसिव का ज्यादा है?
सर एक्टिव के ज्यादा है।
एक्टिव स्कोर टू
बेसलाइन
एक्टिव से ज्यादा है, पैसिव से
सर आई हैव टू से
ज्यादा? ये वो देख, ठीक है नेक्स्ट अच्छा अगर मान लीजिए आपका एक्टिव का ज्यादा है
Then we can add the
तो मोर सीवियर पेशेंट्स
Yes.
रिस्पॉन्स उसका कम होगा और ऐसे प्लेसिबो आम का यू टू लेस सीवियर पेशेंट्स
So I will see
इसलिए
this.
आपका
इसका
रिस्पॉन्स
will नहीं है. Good morning. The title for my poster is A Unique Case of Schizo-Obsessive Disorder with Concealed Conan's Tumor. Schizophrenia and obsessive compulsive disorder are described as distinct diseases but have a complex association at psychopathological level. Neuropsychiatric manifestations ranging from autism symptoms, hyperkinesia, and psychosis are common in tuberous sclerosis. We report a 14-year-old girl who presented with schizophrenia years before the onset of lesion of Conan's tumor, which are a benign cutaneous manifestations of was at consultation, insidious onset of suspiciousness, anger outbursts, self-muttering, social occupational decline, poor self-care for a period of 2 months. Her mental status revealed blunted effect, delusion of reference and persecution, and auditory hallucinations. Her mental functions were all impaired. Her memory, ability to do simple calculations, judgment, and overall intelligence was impaired. Further evaluation revealed that she was born with squint affecting both her eye and showed a delay in developing development milestones and poor academic performance. Her IQ testing revealed a score of 70. Family history was positive for psychiatric disorders. On the basis of the above clinical findings, a diagnosis of paranoid schizophrenia disorder, the patient was given oral risperidone 4 mg per day and remission of symptoms was seen. At 14 years of age, the patient was brought again to the emergency with worsening of psychotic symptoms, with complaint of increased agitation, increased anger, verbally and physically abusive, along with suspiciousness. So she was admitted to the female psychiatric ward for detailed evaluation. Further exploration of history revealed contamination obsession and washing compulsion. She took up to 4 showers per day, each lasting up to 45 minutes, and would repeat sentence multiple times. On examination, flesh, reddish, smooth, soft nodules were seen emerging from the nail fold of the finger. On consultation with the dermatologist, it was revealed that it to be a periungual Conan's tumor. Conan's tumor or periungual or subungual fibromas occur in nearly half of the patient with tuberous sclerosis. The patient was treated with risperidone 4 mg daily and fluoxetine 20 mg daily. Her Yale's Brown obsessive compulsive scale score was 40, which on treatment decreased to 13. Her positive and negative syndrome scale score was 27 and 30, which on treatment decreased to 14 and 16. To best of our knowledge, this is the first case in which psychosis and OCD symptoms appeared more than half a decade before the onset of neurological symptoms. Recent studies have implicated the involvement of chromosome 9p in OCD and chromosome 16p in schizophrenia. That is well known that the causative genes that lead to tuberous sclerosis are tuberous sclerosis 1 and tuberous sclerosis 2, located on chromosome 9p and 16q respectively. Further genetic studies are warranted regarding the exact genetical mechanism by which tuberous sclerosis and these two disorders co-occur. Our case emphasized the relationship between dermatological and psychiatric disorders. The relationship is between the skin and the brain, as they both have same ectoderm origin and are affected by the same hormone and neurotransmitters. This case highlights the successful treatment of two psychiatric disorders co-occurring in patients with a probable diagnosis of tuberous sclerosis. The clinical should maintain a high degree of suspiciousness for the probability of latent tuberous sclerosis and to be open to the possibility of psychiatric comorbidity. Sir, 13 years, but she presented with just psychotic symptoms. At 14 years, she presented with obsessive as well as psychotic. And so 13 years.
Early onset कब कहते हैं? 13 years है. 10 से early. बट आपने एक जगह आप साइकोसिस विद एंड ओसीडी लिखा हुआ है, टाइटल में स्किज़ोफ्रेनिया लिखा हुआ है, और आपका इंट्रोडक्शन में इसमें आप केस रिपोर्ट में जाएं तो इंट्रोडक्शन में आपने स्किज़ोफ्रेनिया ओसीडी लिखा हुआ है। मेथड्स में जा रहे हैं आप, मेथड ना करके आप इसमें केस करते हैं।
सर उन्होंने मेंशन कर
अच्छा
रखा है।
ठीक है, लेकिन यहाँ पे जाएंगे तो फिर नीचे जाएं, हाँ तो यहाँ पे जाएंगे तो पैरानॉइड स्किज़ोफ्रेनिया लिखा हुआ है।
Sir, I've written at 13 years of age, we diagnosed her with paranoid schizophrenia. At 14 years, she presented again to us with OCD symptoms as well. So before that, we diagnosed her. I removed this diagnosis.
नहीं ठीक है, but there has to be a uniform. वापस जाएं, तो ये IQ टेस्ट 70 है, borderline कहाँ? हाँ?
Borderline.
70 to 90 borderline.
Borderline.
Borderline warrants a diagnosis.
So tuberculosis is associated with
With the borderline warrants a diagnosis. No. Whether she needs to address this in diagnosis. Huh? Basically, mental retardation has to become.
So, but this point is going in favor of a diagnosis of tuberculosis. That is why.
That is fine.
But why do I have to mention it?
borderline बोल रहे हो, तो borderline का क्या फायदा क्या होगा? हमें diagnosis में डालना है, क्या करना है? Mental retardation में IQ कितना से कट ऑफ माइल्ड का? वो देख लेना है। अच्छा ये तो 13 years, आप in case of schizophrenia and OCD कर दो।
14 years old.
टाइटल
ठीक है। मैम मैंने एंडिंग में मेंशन करा प्रोबेबल डायग्नोसिस क्योंकि क्राइटेरिया मैंने I will mention it. I will not able to add it because they have mentioned the font size also कि ये रखना है. So I will say it that मुझे could not be done.
इसके बाद आपके पास स्पेस नहीं बचा।
सर उन्होंने मेंशन कर रखा है कि suggested to keep the font size between 26 to 36. So क्या academic मैम बिकॉज हम we reported 14 years old girl who present with schizophrenia and OCD भी ऐड करना है तो at 14 में आया उसके पूरे symptoms तो
इसको लिखिए, ये लिखो adolescence girl,
ठीक है
adolescence, girl in adolescence, adolescent girl presented with schizophrenia. Schizophrenia SCZ आपने हर जगह ही आपको फिर SCZ मिलेगा, सेम शॉर्ट फॉर्म यूज
yes
तो अब आप यहाँ पे आ जाए अपने मेथड पे मेथड पे आ जाए। आई थिंक इट वाज थर्ड पर्सन ऑडिट, आपको इसको लिख लीजिए थर्ड पर्सन ऑडिट। बस पॉइंट इफेक्टिव होता है। ठीक है, ये आईक्यू टेस्ट कब हुआ था?
sir when she was admitted with us when 13
Positive for the psychiatric disorder. Which psychiatric disorder?
sir we do not know the exact history psychologist बताया था मैंने कल
Psycho बताया।
yes
Positive family history was suggestive of psychosis. कौन सा सिबलिंग था, कौन सा डिग्री था, डिग्री लिखना होगा। Then diagnosis of paranoid schizophrenia.
सर यहाँ पे भी
disorder भी लिखा schizophrenia disorder.
सर इसमें डायग्नोसिस की जगह प्रोबेबल
Cases of above findings, provisional diagnosis. schizophrenia. Was considered, patient was started on, was initiated on oral risperidone, bracket में up to 4 milligram, titrated up to 4 milligram. ऐसा नहीं था कि 4 milligram में डे बंदा दे दिया, तो ब्रैकेट में जरूर लिख देना था ना, titrated. And response was seen. Remission मतलब पेशेंट ठीक हो गया, response ज़्यादा बेटर. Subsequently, after 1 year, patient, what worsening क्यों हुआ psychotics में, patient left medication.
No, sir. Sir, I wanted to ask, could I add that the worsening was seen because maybe the dermatological manifestation was seen? Sir, वो था नहीं, उन्होंने but
Why
medication.
worsening? Did they discontinue the medication?
No, sir. The mother denied it.
तो आप बोलेंगे after 1 year, even on continued treatment, patient had worsening. अब evidence ही हटा दी, worsening of psychotics. Over S की जगह self care. Subsequently, warranting admission. बाकी 3 लाइनें तो ऐसी बच जाएंगी. She was admitted to female psychiatry ward for detailed evaluation. था दीजिए. Subsequently, warranting admission. Further exploration. आपने लिखा है ठीक है. ठीक है. जो स्पेस बचेगा उसका बोलना है एंटीसाइकोटिक्स वर ऑप्टिमाइज्ड. आपको रिजल्ट्स होने की जरूरत नहीं है, मत दो रिजल्ट्स करके, नहीं वैसे वाले रिजल्ट नहीं, उसका ट्रीटमेंट लिखेंगे, केस में भी ट्रीटमेंट आ जाएगा.
तो रिजल्ट में कुछ ऐड करना है?
नहीं वो आप सीधा डिस्कशन में चलेगा.
So they have suggested, they have not written exactly कि added, they have just suggested that add headings of A.
हेडिंग कंपल्सरी नहीं है, तो इंट्रोडक्शन प्लीज
हाँ तो सही आ रहा है सर. तो यहाँ पे केस रिपोर्ट करके और सीधा डिस्कशन कर देंगे.
स्पेस बच जाएगा.
नहीं साइकोलॉजिस्ट का
तो मैं कह रहा हूँ बॉर्डर में आ जाएगा बिल्कुल. बॉर्डर लाइन 070 to 90.
मैम उनका असेसमेंट करके 70 बॉर्डर लाइन लिख रखा था.
तो ना 5 का तो देखो चलता है, 75 में तो 5 का प्लस नहीं चलता. 5 का तो आईसी टेंडी कहता है कि आपको गेट मेंटेन करना है. एंड लुकिंग एट हर उनका ब्लंटिंग नहीं पड़ा भी नहीं है, वो सब कर नहीं. नाउ यहाँ पर जो ये आपने एंड किया है ना 45 मिनट सेल्फ के, यहाँ पे आपको ट्रीटमेंट सब्सिक्वेंटली हर एंटीसाइकोटिक्स और ऑप्टिमाइज्ड. अब 4 मिलीग्राम से तो 8 मिलीग्राम में चली गई थी.
यस सर.
अब लिखी पड़ेगी आपको अप टू 8 मिलीग्राम, टाइट्रेटेड टू 8 मिलीग्राम एंड फ्लोक्सिटिन वाज एडेड. ना ब्रॉड ब्रिंगिंग आउट ये जो आपके स्केल्स हैं
ये यहाँ पे है,
पर ये आपको 4 से 8 मिलीग्राम पे लेकर देन आपको ये आ जाएगा एग्जामिनेशन. एंड ये जो स्किन वाला आया था ये कब आया था
सर? इसी के इन्हीं के सिम्टम्स के साथ सर, ओसी सिम्टम्स के साथ ऑन एग्जाम.
ठीक. नेक्स्ट
सर इसमें मैंने वो स्किन डर्मेटोड्स वाली चीज भी ऐड कर दी थी और जीन वाली भी ऐड कर दी.
लास्ट लाइन लिखते हैं इंटरेस्टिंगली पेशेंट रिपोर्टेड significant response to the psychotropics. पे जो केस होता है ना वहाँ एक लाइन जो डाल दी थी कि ये वो सोशल एडमिनिस्ट्रेटर पूछेंगे. यहाँ पे साइकोसिस
सर
या साइकोलॉजी
साइकोसिस की जगह सर हर जगह से सोचो।
मेक श्योर कि सारे करेक्शंस हो जाएं।
Good morning. The topic for my today's poster presentation is approach towards pseudocyesis management in non-pregnant women. Introduction. Pseudocyesis is a false belief of being pregnant in a non-pregnant woman. Delusion of pregnancy is a unique form of hypochondriacal delusion. It can occur in affective and non-affective disorders, epilepsy, organic brain conditions, and certain medical conditions. Since the first case report by Esquirel in the early 19th century, it has been repeatedly described in literature. Delusion of pregnancy with a postpartum onset is rare, and only a few cases scenarios are described early. Case report: a 26-year-old married Hindu female belonging to a lower socioeconomic status was referred to psychiatry with acute psychotic symptoms 10 days after she gave birth to a baby boy by an uncomplicated vaginal delivery at home. After 3 days of delivery, patient started reporting of abdominal pain and fever, for which she was taken to a government hospital, where after evaluation and vaginal examination, soaked cotton balls were found in the cervical region. By the 5th day after the delivery, she developed behavioral altercations, became increasingly upset and withdrawn, neither slept nor ate, but lay naked in the bed, fully neglecting her child. She developed bizarre delusions that her child is still inside her womb and was seen touching her womb, claiming to be pregnant. On admission in psychiatry department, she was uncooperative and answering in monosyllables. She appeared lost and was seen muttering to self while searching for a baby inside her clothes. She felt pulsations in her abdomen, which she attributed to the movements and the heartbeat of the unborn fetus. The aim of this case report is to say on physical examination, pallor was present. On MSc, her attitude was evasive, psychomotor activity was decreased, affect was blunt with restricted range and reactivity, not communicable and immobile, preoccupied with the thoughts of a delusional unborn child, insight of grade 1. On blood investigation, the hemoglobin was decreased to 9.1 gram per deciliter and ESR was raised to 36 mm first hour automated. Renal and thyroid functions were normal. Ultrasound, whole abdomen showed bulky uterus with heteroechoic content of 60 cc suggestive of retained products of conception. She was started on injectable haloperidol, promethazine, and lorazepam 4 mg in divided doses. Her brief psychiatric rating score was 46. During the short hospital stay, the patient improved gradually and her injectables were down tapered gradually and was started on oral olanzapine 5 days. The patient was discharged on the 6th day of hospital and on olanzapine 10 milligram in 2 divided doses, and the BPRS score reduced to 22, with the advice to follow up in the psychiatry outpatient department in 15 days. Conclusion: this is an unusual case of postpartum delusion of pregnancy. Simon et al. 2009 reported 2 such cases, which were the only rare descriptions of delusion. The first case had pre-existing schizophrenia and the other one had positive family history of pseudocyesis and schizoaffective disorder, but she had no pre-existing psychiatric illness. Various factors like psychodynamic and psychosocial factors of cognitive models and neuroendocrine factors explain the delusion formation in pregnancy. An integrating factor model can provide a more individualized approach. Regarding the motivational aspects of the postpartum delusion of pregnancy, it could be an attempt for extending the pregnancy time to avoid the stress of the role of the mother. Combination of cognitive and supportive psychotherapy, especially for the resistant cases, is advised. Cognitive therapy focuses on cognitive distortions, whereas supportive psychotherapy addresses the motivational aspects. It helps the patient to cope with the stresses of the postpartum period. These
How many
are
differences you
the same.
see?
So then we start.
अभी ये जो आपका ये भी करेक्शंस कर लीजिएगा. साइमन एट ऑल, if you're following this reference pattern, you can't write 2009. Simon and colleagues, and then you can write the 3. Okay. Why you have added 7 references? The काम भी कितने हैं? 4, 5, 6. Last one is 4, 5, 6. I think you can only put 5. 4 and 5 रख सकते हैं, 6 हटा सकते हैं. UTI and delusion of pregnancy का क्या फायदा था? Postpartum वाले. I think then again, I think आप लोग डिस्टर्ब हो गए क्योंकि आप लोग उस पैटर्न को लेके चल. सेम है कि बस इंट्रोडक्शन, केस रिपोर्ट एंड डिस्कशन बस. ठीक है. एंड व्हाट शुड द टाइटल, व्हाट यू वांट टू शो देम?
Approach to the patient.
Why improve management antipsychotic? ठीक हो गया. Important is delusion of pregnancy
In postpartum.
So up to pseudocyesis and with postpartum. This is the main.
Postpartum.
This is the main crux of the case. Pseudocyesis and postpartum. Rare cases. Your introduction is okay. Srinivas, is it fine? ठीक है. जो आप 4, 5, 6 हैं उसका एक और रेफरेंस हटा दें. Go for 3 or 4 references. Case report में then it is fine till you have finished. Next. ठीक है. भैया बीच में सब गड़बड़ होता है. Aim methods. Mental status also you will write very brief. Here you have to also mention whether she was accepting this belief despite seeing a newborn child.
But I've written that she was uncooperative. Interview.
But whether जो वो बच्चा उसके पास लेके जा रहे थे तो still she was saying that.
Yes, she was saying.
आपको आना पड़ेगा. She was. What was the reaction of her when she was seeing the newborn baby? She was harboring similar beliefs despite seeing the newborn child. ऐसा कुछ डालना पड़ेगा कि establish it even. Mental status में सब थोड़ा brief कर दीजिएगा. Investigations are fine because you retain products of conception से भी जा रहा है. Then your management is okay. And discussion is also fine. Motivation वाला aspect is good. And then अभी सर management हमारा aim ऐसा होता है. Aim is to display this psychopathology. आप management बता दे रहे हैं कि हमने इसे adequately manage कर लिया. ठीक है. वहाँ पे management part को cut short कर सकते हैं. अभी जिसको भी बोल सकते हैं. और यहाँ पर neither shared any family history nor past history. एक आपको discussion में management की जगह ये line डाल. In our case was unique in the sense that it didn't have any risk factors or any predispositions. ठीक है.
So this have written in results of case
ये
of
आप
the
लिख लेना. ये सब पता लगा कि ये ऐसे हो जाता है. ठीक है. Any questions? ठीक है. वही pseudocyesis and postpartum onset. Pseudocyesis with postpartum.
Rare case.
आपको